So good morning and welcome to the PHFA Certificate in Elder Service Coordination Program, and today's topic is medication and substance abuse. These webinars, in conjunction with specified sessions at the PHFA Housing Services Conference, will enable you to be eligible to receive the Certificate in Elder Service Coordination, which will be issued in partnership with PHFA and the California University of Pennsylvania Rural Communities Institute. Our presenter this morning is Linda Shoemaker. And Linda is a registered nurse who is currently serving as training coordinator of the Pennsylvania Behavioral Health and Aging Coalition. She has previously been employed as the executive director of the coalition, where she advocated for funding and received over $325,000 to outreach and educate older adults regarding behavioral health issues. She also has worked at the Central Pennsylvania Psychiatric Institute, Penn State College of Medicine in Hershey, PA. Ms. Shoemaker has extensive clinical experience working in community mental health, geriatric assessment teams, and in long-term care. In addition, she has been an instructor of psychiatry at the Pennsylvania State University College of Medicine, co-chair and founding member of the Pennsylvania Mental Health and Aging Coalition. She has served as a member of the Older Adult Committee of Pennsylvania Office of Mental Health and Substance Abuse Planning Council and a member of the Long-Term Subcommittee of the Medical Assistance Advisory Committee. She has served on the Board of Directors for the Pennsylvania State Alzheimer's Association and the Advisory Board for the Central Pennsylvania Chapter of the Alzheimer's Association. And you might also remember that Linda did our presentation regarding Alzheimer's at the conference, and that session was also part of the CESC program. Good morning, Linda, and thank you for doing our presentation this morning.
Good morning, Alicia. Thank you very much. All right, I'm going to go ahead and get started because there is a pretty big topic and the PowerPoint is pretty large. I'm sort of going to try and consolidate things to you, but if you have questions, please hold them to the end. You may want to jot them down so you remember, and I can talk about it at the end. Well, I'll save about 10 minutes. So substance abuse and medication abuse and misuse in older adults is a huge problem. It has become a huge problem over the past probably 10 years, and I'm going to show you some statistics. They actually have been looking at this since before 2000. And when I was executive director of the coalition, one of the things I was looking for was, of course, money, but all the funding was going for substance abuse in older adults. So it is a large issue, and if you look at the first slide, it talks about how common it is. One of the biggest difficulties is it's not very likely to be recognized. It causes a lot of problems because there's a lot of substance abuse issues in hospitals where people don't even know what's going on. It's not recognized easily or even addressed easily. And one of the big issues that we're all hearing about on the news is the prescription drug abuse, which is actually becoming as common as alcohol abuse in older adults. So we're going to talk and address today illicit drugs, use of illicit drugs, misuse of prescription medications, over-the-counter medications, alcohol, and any combination of above. And that's what we'll see is sometimes a lot of combination, which for older adults who, the physical changes that accompany aging can cause really, really severe problems and lead to hospitalization, lead to long-term care placement. Nicotine, and I put this in because the question is about nicotine. However, and if you look at the DSM-5, nicotine is considered a drug. And what they say is any smoking is considered a drug abuse in places the older a person for negative health consequences, especially respiratory and cardiovascular illnesses related to smoking. So people should not be smoking even the new electronic cigarettes. No, is what you will hear through healthcare providers. I also wanted to just mention what's called process addictions. You're going to be hearing more and more about those. It is a behavioral addiction, but it's a condition in which a person is dependent on a form of behavior. The most common one is, of course, gambling, lottery being the most common, casinos being the next. And I bring that up because of the age relationship. Behavioral addictions do not involve drugs and alcohol, but they are very similar to chemical dependencies, and there is constantly reward-seeking behavior. Sex can also be a process addiction, and we're also one of the big issues that you're going to be hearing about, I think you're really going to be hearing about in the coming years because the boomers is they aren't sure how to classify it, first of all, but increase in new HIV diagnosis as an individual over 50 are becoming a problem. So just some things to think about and some things to that you'll probably be seeing in the future. Now, substance abuse and medication abuse, and this is from a report that came out in 2003, I believe. But it's estimated the number of old, just so you can see how big of a problem this is. I mean, you'll see some of the statistics will actually go up that you'll see how it has grown and why it is such a big concern. So it's estimated the number of older adults in need of substance abuse treatment will increase from 1.1 million to 4.4. So that's over twice, over double. It's due to a 50% increase in the number of older adults. So you have the increase in the population, but it also is due to a 70% increase in the rate of treatment need. So in other words, more older adults are going to be abusing, and that is the boomer generation. So once again, specific issues for generations. And you'll see the current over 50 group makes up about 10% in substance abuse treatment. That's that over 65 mainly, and that's alcohol. However, it's the boomers that are going to really pull in the biggest problem. So what we're looking at now is a challenging issue because we're taking care, and I run a clinic 3 days a week, and I can tell you at least currently right now I probably have about 5 individuals in my clinic who are substance abuse users. And what I want you to think about, and they're over 70, over 80, some of them. So I want you to think about meeting the needs of these older adults and the difference it's going to be in planning for us baby boomers, because I am part of that population. So totally different approach, totally different process, and you can see the impact, and I also want you to truly think about this because you can see the impact of the baby boomers in the legalization of marijuana coming across the country, and that is the influence of the baby boomers. So those issues are going to be coming forth in the years to come, in the next 10 years. Actually, they'll say till 2020. So in 2011, Substance Abuse and Mental Health Services found, and these are things to really think about, this is SAMHSA, which is Federal Substance Abuse and Mental Health, found that adults aged 50 to 59, the current rate of illicit drug increased from 2.7 to 6.3, and it was the most common drugs were opioids, cocaine, and marijuana. 2010, okay, estimates of individuals having one or more substance abuse or mental disorder were 14 to 20% of the older adult population. So in those currently in treatment, over 65, it's alcohol, but 50 to 64, the boomers, it's more extensive, okay? And this current population, it's not just alcohol, it's prescription drugs, abusing prescription drugs, alcohol in combination with prescription drugs, medications over the counter, or alcohol only. The illicit drug statistic, this is actually not from 2007, it's a little later, it has doubled in the past couple years, up to 4.1%. So we're seeing huge issues with that, and I have more slides on that. I have some more updated slides. And I want to talk about illicit drugs first. And the National Survey on Drug Use and Health, which is NASDA, defines illicit drugs as marijuana, which I'm sure will be changing on some level, hashish, cocaine, inhalants, hallucinogens, heroin, or, and this is what we're seeing huge problems with now, prescription-type drugs used non-medically. Okay. Non-medical use is defined as the use of tranquilizers, pain relievers, stimulants, sedatives that were not prescribed for the respondent by a physician or are simply being used for the experience or the feeling that they cause. And that includes those Oxycontin, the Percocet, the Darvon, CNS stimulants such as Ritalin, minor tranquilizers, Valium, Ativan, Xanax. I had somebody call me in the clinic who is taking, I think, 3 to 4 milligrams of Xanax a day. For an older adult, that's a hefty, hefty dose. Sedative hypnotics like Seconal, amibarbital, things like that. So current illicit drug use by this generation, the older adults that we're taking care of, is lowest. And this is the caution back in 2001. This is one of the things that I found when I was trying to get grants and funding for the coalition. What the concern is and why the funding was going towards that is because half baby boomers have tried illicit drugs, and what they know is that birth cohorts that experience high rates of illicit drug use in earlier age have shown higher rates of use as they age. So they literally go back to it. And if you think about it, I've seen a video from the Hanley Center in Florida, which is one of, if not the only older adult treatment center in the country. They were talking about what happened in the 60s and the early 70s, that illicit drug use was normalized, whether it be LSD, which was, being used at Harvard and everything else in testing, or marijuana use. So it was actually normalized. So that's why you're seeing a huge increase with the baby boomer generation, which is why you're also seeing it legalized in some states. So the studies, and this is from 2006, and you'll see this repeated again and again, the baby boomer generation, rates of alcohol and drug use is going to continue to increase into past 2020. So it's a huge concern, and it has been a huge concern, just so you know, for at least 15 years. So this is from 2011. An estimated 4.8 million older adults 50 and older used an illicit drug in the past year. Marijuana was more common at that point in time. However, non-medical use of prescription drugs was higher among those 65 and older. So they got a prescription. They thought, it's from my PCP, so it's okay to go ahead and use it. So that's one issue. These are the other things to think about. And to look at this slide, you need to look at the age rate. So between 50 and 64, the rate of illicit drug use increased from 2002 to 2013 from 2.7 to 6.0%. For adults 50 to 54, a younger, it increased from 3.4 to 7.9. From 55 to 59, it went from like 2% to almost 6%. And 60 to 64, it went up. It was not as great as the younger population. But once again, we're seeing the baby boomer reflection in that. Then this is the scary thing. When I saw this, I was so blown away. The proportion of older adult admissions reporting heroin as a primary substance of abuse more than doubled. It went from 7% in 92 to 16%. Cocaine also increased from 3% to over 11% the same year, and that was 2008. What we also know is women, and what they projected back in the early 2000s, what it was going to be women were going to use non-medical use of prescription drugs, because that's what it's really been consistently. Women have abused prescription drugs. But what they're finding is marijuana use is increasing as well. Men abuse both prescription drug as well as marijuana. So big issue, of course, is this opioid problem that you're hearing. I think Obama announced the other day that he is putting more money into some Northeast states where there's a huge problem of opioid deaths, overdoses and things. So, and different approaches are being tried. And you're going to hear about that, and I really encourage you to listen about that on the news, because it's a huge problem that's going to hit all of us across the state, whether we live rurally or urban. There's different nuances to it. There's bath salts in some rural areas and all sorts of odd things that, I was like, what the heck is that? But you're seeing these things happen. More synthetic marijuana coming out, all sorts of issues we're seeing. So the real concern is Americans are only 4.6% of the world's population, but we consume over 80% of the world's opioid supply. Okay, overdoses from 2004 to 2007, that's an old stat, is in the 45 to 54 age group. The users of heroin and other opioids, as they get older, the risk of overdose, it increases dramatically. So this boomer population, even though, and that was 2004 to 2007, that's the boomer group. And so the death rate is going to increase even higher than it was back then. So that's just a caution. This slide, actually, this is from National Prescription Drug Audit from 2012. It talks about how opioids are being prescribed for seniors, and it's the largest growth. And it's a lot of it, there's a lot of concern because the physicians are prescribing, and then pain advocacy organizations are supposedly receiving kickback from drug company, and they say that opioids are okay for seniors. So, it really is. It's a dilemma. It's an ethical dilemma. I have a mother who had severe chronic pain because she had severe degenerative disc disease in her back, so her spinal cord was literally being crushed. And she was on OxyContin, 20 milligrams 3 times a day, and she's like, she wouldn't take it because she was afraid of getting addicted. And I'm like, Mom, it doesn't matter. It really doesn't matter. What matters most is your comfort. So what we're looking at is ethical considerations as well in the older adult population who have complicated medical problems. So there's these dilemmas. It's not black and white. But what we need to be doing is addressing it more openly, addressing it through legal channels, addressing it through education, which we're going to talk about at the end. Oops, sorry. And this is the other concern. Opioid use has increased substantially, but its effectiveness is only for short-term acute pain. A lot of adverse consequences. Long-term use actually increases healthcare costs, disability rates, surgery. I've seen insurance companies come out addressing opioid use because they can't get these people back to work. They're on disability. So you're going to see all sorts of things changing, addressing this in the years to come. And this is from SAMHSA 2014. Abuse of prescription drugs, particularly prescription opioids among older adults, has become worse over the next several years. So, and what's sad is you see that this was talked about in 98. Like I said, the early 2000s, but 98 was when SAMHSA started talking about it, and we haven't addressed it yet. And part of my policy questions to people always is, if we know this, why aren't we addressing it early on? We sort of like stick our heads in the sands and say it's really not going to happen. But research shows us, projections show us, and they've been right. They've been right again and again for many, many things. This is from 2015, just in June, and I want to put this in here for you just to show you some updated stats. If you look at using illicit drugs in the past month, if you look at the 50 to 54, that's the blue line on the top. So you can see how that's gradually grown up. 50 to 59 also has gone up. It took a dip in 2013. And the older adult population, which also is considered boomers, just so you know, 60 to 64 is still considered boomers, but they're the older group of boomers. It has not gone up as sharply. So just things to look at and things to be aware of. And once again, these are things that we've been predicting for 15, 20 years. The current illicit drug users from 50 to 59 has more than tripled from 2002 to 2012, from 900,000 to more than 3 million. So huge concerns coming up. So we're now going to talk about medication abuse and misuse. And as you all probably know, that adults 65 and older consume more prescribed medications and over-the-counter than any other age group. They're 12% of the population consume about 34% of all prescription meds. They use more than 76% use 2 or more prescription drugs a month. 37% used 5 or more. It's one of the fastest-growing health concerns. So 70% of all over-the-counter medications, and the average adult over 65 uses 11 different prescriptions. Now, I'm talking prescriptions a year. The other concern is 1 out of 4 prescriptions are actually psychoactive. This is the other scary thing, is that 60% of prescribed medications are not taken according to directions, and approximately 140,000 people die as a result of that. 1 in 4 older adults skips dosages or does not fill the prescriptions due to the cost. And any older adult who fails to take their medications or compliant with their medications experience a significant decline in their health. So once again, that's a health literacy issue, which we'll talk about. The other issue is the adverse reactions, and there's a difference between having a side effect of a medication and having an adverse reaction, because a lot of times people will have a side effect and they'll say, I'm allergic to it. It's very, very different. And I can tell you, because in my clinic I have individuals whose charts have like Tylenol as as an allergic reaction, and they may have had a side effect from it. Maybe they took too much and they got an upset stomach or something like that, but they aren't allergic to it. So older adults experience 2 to 3 times as many adverse reactions as younger adults. In one half, the individuals who are hospitalized for adverse drug reactions are over 65. The other issue is mixing prescription medications and alcohol, which we will also talk about. And I can tell you in acute care, they don't assess good for alcohol consumption, so a lot of times people may have fallen and fractured a hip and gotten hospitalized and go through withdrawal in the hospital, and the hospital staff doesn't know what's going on. Is because they're going through withdrawal from alcohol. One of the biggest, this is the problem with medications and aging, because we have these are normal age-related changes affect how we process medications and alcohol. So our body fat decreases, our fat increases, the total body water decreases, which is one of the reasons that they really encourage older adults to keep drinking water. There's a decrease in the stomach's ability to metabolize alcohol. There are liver and renal, your kidneys and your liver function slow down as you get older. And then, of course, there's neurotransmitter changes within the brain itself, so that people are more apt to have effective medications. They stay in their system longer. I've seen people take 5 to 10 days to get, like, Darvon out of their meds, and they were acting drunk, and it literally, you'll see it gradually go out, and then they're fine. 20% of older adults have problems with medications or alcohol, and they don't even know it. Older adults are prescribed more long-term prescriptions as well as multiple prescriptions, as I stated before. There's a larger percentage also that use over-the-counter, and I don't know if you all saw, because my drug of choice for joint pain is ibuprofen, and there's an increased risk with routine taking of ibuprofen with, I think it's heart attack and stroke, just came out a couple weeks ago. Older adults use herbs and dietary supplements along with their prescriptions, and do we know, because herbs and dietary supplements are not regulated by the FDA in this country, do we know what they're actually mixed with? Okay. There's also the risk for prescription drug abuse, where they're taking these medications that they don't really need, and they actually become accidental addicts, and then they can't stop. Older adults experience more adverse health consequences, comorbid illnesses, whether it be congestive heart failure or diabetes or kidney disease. They have increased risk for drug interactions. And once again, as I said, drug metabolism, they stay in your body longer, whether it be an antipsychotic medication, whether it be a pain medication. They literally stay in your body much, much longer. So overuse, underuse, and irregular use of prescription or over-the-counter drugs are actually forms of misuse. The medications of particular concern are those for anxiety, which are things called benzodiazepines, and that's Valium, Ativan, Xanax, Xerox, things like that are also addictive. Depression medications, insomnia medications, and other mood disorders, and 25% of older adults do use psychotherapeutic drugs. Other concerns are the over-the-counter and the herbal supplements. And I can tell you in my clinic, when people come in for an evaluation, I tell them just to pull everything that they're taking. I do the brown bag approach, put it in a paper bag and bring it in. And I don't care if it's an herb or it's a vitamin, just bring it in so we can take a look at it and we know what's going on. This is a list from the Hanley Center of the most common medications of abuse. And this is for this current generation. So alcohol, benzodiazepine, once again, that's Ativan, Valium, Xanax, over-the-counter sleeping aids, cough syrups, opioids, marijuana, hallucinogens, heroin, crack cocaine, stimulants. And so the risk factors for medication misuse are taking extra doses, missing doses, not following instructions, taking the wrong medication, using meds that are expired, not knowing about side effects, not knowing that you need to take this for 10 days consistently for your pain to go away, sharing or borrowing medications. Oh, this worked great for me, you should try it. Mixing medications or drinking alcohol while taking medications. going to multiple physicians to get more of the same, or going to your PCP and then going to your arthritis doctor and getting the same medication, going to multiple physicians who are unaware of people's complete medication regimen, and there are people out there who actually do it. There's inappropriate prescribing, especially for women. The failure to tell doctors about over-the-counter herbs and vitamins. When I see my nurse practitioner every year, I make sure they know what I'm taking because I take vitamins, so I want them to know what else I am taking. People can have problems because they have memory problems. They have problems understanding why they're taking the medication. They may not be able to read the print. And not many people have heard about health literacy, but health literacy is the ability to understand your health problems and to take action to take care of them. And we have an extremely high health illiteracy problem in this country. It actually costs us over, it's close to $300 billion a year because people don't understand how to take their medications. They don't take them properly, or they can't afford them, and then they stop them, and then they get hospitalized. So huge issues with health literacy. And I have a handout here to help you with that, with addressing some of that with your clients. So misunderstanding or missing instructions, either hearing, vision, or language barriers. And the thing to remember is really to emphasize with people about medications and alcohol, that even social drinking, maybe having one drink or two or a glass of wine with dinner at night, can be a problem depending on the medication the person's taking. Like even taking aspirin or arthritis medication and drinking, you can increase your risk of having a bleed, a GI bleed. Tylenol can cause liver damage in people having more than 3 drinks a day. And alcohol, with the antidepressants, with sleeping medication, any of those medications, it's a central nervous system depressant. So it can really cause people to become sedated. It increases fall risks, all those types of things. High doses sedatives mixed with alcohol actually can deplete your respirations, that you can die. High blood pressure, diabetes, ulcers, gout, heart failure, drinking alcohol and taking medications, those medications can make those conditions worse. Antihistamines, cold medicines, allergy medicines, sleeping medications like Tylenol PM, that has Benadryl in, which is an antihistamine, that can make people worse and impair coordination. And once again, the gait disturbance, falls, things are really a concern. So this is tips for preventing medication errors, and I put this in here because this addresses the lack of health literacy problem. And I think there's actually there's 2 slides for this, that if you want to cut and paste and use as a handout, you can. But always, this is what we all should do. Ask why each medication is prescribed and what is it intended to do. I take my Diazide to help bring down my hypertension. Hypertension is high blood pressure, and the Diazide gets the extra fluid off. So make sure you understand when and how to take it. Okay, with Diazide, you may want to take in the morning so you're not up all night going to the bathroom. So take the medications exactly as directed by your provider and ask to do if you mess with dose. Always take a list of your medications and their dosages with your healthcare provider at each visit and with each physician that you see, whether it be a cardiologist, whether it be a neurologist. Okay? Use the same pharmacy for all your prescription medications, and pharmacy plans are actually keeping a check on that. They can tell you if you're getting this from your 90-day supplier or from the local CVS. And they'll tell you, no, you can't have this because you just had this refilled. So there's, people don't like the government or messing in with us, but this is actually a good thing. You need to read labels on your medication carefully. If you drink alcohol, ask your healthcare provider about the safety of drinking it while taking it. And if you think you're having any problems or side effects, you call your healthcare provider immediately. Okay? Ask questions. And, one of the things that I always caution people about, if you go into the Internet to look up your medication, or if you read it in the PDR, remember that they're required to list all the potential problems or side effects that you could be having. So, certainly I think people need to be educated, but it'll tell you that this side effect only happened to 5% of the people. So they're usually minuscule. For people to have a true allergic reaction to a medication, is sort of rare, and like I said before, I always caution people, is it an allergy or did you just take too much on an empty stomach and you're having trouble with it? So is it just a side effect? All right, we're going to talk a bit about alcohol now. And there's some myths that it's okay for older people to drink alcohol. It's okay to feel sad and depressed. That's a normal part of older. Over-the-counter medications, you can take them with alcohol. Very few women become alcoholics. And if an older adult says that drinking is their only pleasure, it's okay. And I've had families actually tell me this in the clinic. It's okay to let them continue to drink. Okay? Because once again, think about all the physical changes that happen, thinking about fall risk, thinking about all the things that happens with this. The problem with older adults is that alcohol and substance abuse is less likely to be recognized. They don't have a good history. Okay? People don't address it. That 85-year-old woman couldn't be drinking alcohol. Alcohol-related complaints, whether it be depression, whether it be tiredness, whether it be bruising of things, may be related to other medical. They may be mistaken, rather, for other medical or psychiatric problems. Older people live alone. They drink alone. They don't have job problems. There's usually no legal problems. It was funny. I was talking at one of the local hospitals in Harrisburg. Oh, it was probably like 10 years ago, and we were talking. I was doing a general overview of older adults and mental health issues, and I was talking a bit about substance abuse, and the ER nurses were in the room, and they were talking about this 85-year-old woman who hit one of the bridge embankments in Harrisburg, one of the bridges going across the Susquehanna, and wasn't hurt badly, but she came in and her blood alcohol level was like 3 times the normal. And I'm like, I said to them, well, how do you know? Because of liver change. They said, when it was funny, because they said when the police came in to interview her, she actually played possum, so that they thought she was sleeping and they didn't interview her. So it was obvious to them that she had a long-term alcohol problem. So, you know, we may think they're cute little old ladies and they aren't drinking when in fact they are. And because of our, you know, sort of like lack of knowledge and things, we really need to be looking at it. This is a proportion of older adult admissions who reported alcohol as their only substance of abuse actually decreased, okay, from 87% in 92 to 58% in 2009. Combination of alcohol and drugs actually increased from 12% to 42%. And comorbid psychiatric issues, and I will talk about this because it went from 10% to 31%. I think part of that is because we're dropping the stigma of psychiatric problems in the past 20 years. And so I think that's a good thing. I think people are actually saying, I'm thinking I'm depressed and that's why I'm drinking, so I need, you know, not only treatment from my alcohol, but I also need treatment for my depression. But the thing is that what we're seeing is alcohol decrease and drugs increasing, which is, once again, the boomer generation. Healthcare settings, there is a much higher prevalence of alcohol and substance abuse, and that's probably related to physical problems, falls, fractures hips, automobile accidents, things like that. This is a spectrum of older adult drinking. About 60% abstain, 20% are at risk, and we're going to talk about all this. 18% are moderate, and only about 2% are dependent. And this is actually from the early 2000s. This is from University of Pennsylvania. They had done, under the PRISM study, they had pulled out data on, they actually did phone calls for older adults and pulled out data on older adult, and this it is. So at risk is a potential for adverse consequences. So these individuals, their frequency and quantity probably haven't changed, but they're starting to experience problems because of age-related changes in metabolism and combining alcohol with medication. So, you know, if you have a glass of wine or two with dinner, you've always had that, but it's going to change as you get older. Early onset are these people who've abused alcohol all their life and grown older without treatment. They have a higher incidence of psychiatric comorbidity. So that's part of it. So not only do they need to be detoxed, they also need to have their psychiatric comorbidity treated, whether it be depression, whether it be schizophrenia. There's also intermittent, which is periodic. These are very much the same as early onset, but these are the people who do binge drinking. Then there's late onset, and this is people who develop alcohol problems due to the associated losses and stresses that accompany aging. It's about a third of alcohol problems, and it is a much rapid progression to addiction, usually less than a year, and it is a significant problem for women. So these are older women who have maybe lost a spouse, maybe families moved away, so they're isolated. So it's really, really significant. So, and we're going to talk about some prevention things with that as well. Alcohol use appears to decline with age, but the lower levels have more of an impact. I can't stress that enough. 66% of reported cases of alcoholism among older adults are early onset, but 33% are late, and it is often overlooked. So there needs to be much better screening across the board. Risk factors for late onset being female, loss of social and economic support, death of a spouse, friends, and other family members, separation from children, social isolation, history of mental health problems, anxiety and depression, loss of job, maybe related income, social status, self-esteem as a result of retirement, loss of mobility, impaired vision and hearing, insomnia problems, people drink to sleep, declining health because of chronic illness, lack of interesting activities, and a family history of addiction. So 1 drink is equal to 1 12-ounce can of beer, 8 or 9-ounce bottle of malt liquor, 5-ounce glass of red or white wine, a 1.5-ounce shot glass of hard liquor, and that's 80 proof. So if you're talking 100 or higher proof, it's going to be even less. And the consensus panel, and this tip consensus panel is like the Bible of drinking. And this came out from SAMHSA in 1998. Men no more than 1 drink a day, maximum of 2 on special occasions. Women, of course, somewhat lower than men. Okay. So alcohol can trigger increased risk of hypertension, heart disease, and stroke. It impairs the immune system. Cirrhosis, liver diseases, causes problems. It decreases bone density. Okay. Chronic pain, causes internal bleeding, causes ulcers. Increases the risk of mental health problems such as depression, anxiety, amnesia. Increases the risk of cancer of the stomach, the larynx, the pancreas, liver, and the esophagus. Causes nutritional disorders. Believe it or not, it does not help with sleep. It causes this thing called rebound, where if you drink before you go to bed, you usually wake at 2 o'clock in the morning, and a lot of times people can't get back to sleep. Okay? So it's an overall increase in mortality across the board. Protective factors, and I keep this slide in because I think it's really interesting and very important for older adults, especially for those of us who work with older adults, that they need access to resources, health care, good health care, housing. They need support networks. They need social contacts. And that's one of the reasons, especially in housing, having group meals, I did some outreach in Cumberland and Perry County a few years, over a long time, actually, off and on for a couple of years. And one of the things I always did is I'd go over and talk to them about health literacy, and I'd have them do, just hold a dinner in the evening, and then I would come talk, and everybody would bring something, and it would be a big communal type of thing. That really is important. Community activities, supportive family relationships, education, addressing that lack of health literacy issues, wise use of medication, and once again, a sense of purpose and identity. And I think as the years go, one of the things that's happening with this boomer generation is they're much more into volunteering, and they're much more in, so you're going to see more things come in place for older adults as the next few years come in. And we should be thinking about what we can develop as well within our own constructs of our employment. Co-occurring disorders are a huge problem in older adults with substance use disorders. So they can have physical problems, as I said, congestive heart failure, diabetes, hypertension. They can have cognitive issues. They can have behavioral issues. The mental health problems that you'll see with substance abuse disorders, social phobias, generalized anxiety disorders, agoraphobia. And what happens is people start treating these, instead of going to a doctor and getting help for it, they will start treating it with alcohol or other substances. Post-PTSD, huge issue. That's one of the reasons why individuals are coming back from Iraq and Afghanistan abusing opioids and abusing alcohol as PTSD. That is starting to be addressed, but it hasn't been addressed in a long time. Panic disorder, major depression. I've had people with schizophrenia come into the clinic and they drink because it helps the voices go away. And they have severe alcohol problems as well as being schizophrenic. So co-occurring, it's about 48% for people 50 to 64 years of old. It is over 61% for those 65 and older. And you will see, I have somebody in the clinic right now who has dementia, who, well, they think he has dementia. They're trying to get him in to see us, but, you know, you can't determine if he has dementia if they're drinking because it affects people cognitively. And he drinks like whiskey and a lot. And, you know, in order to assess the individual, they really need to be off alcohol. So really big complicating issues. So in summary, because I want to spend like the last half hour talking about what we can do, in substance use disorders in older adults are underestimated, they're underidentified, they're underdiagnosed and undertreated. There's often comorbidities, you know, whether it be physical or behavioral health issues, mental health issues. Prescribed medication and over-the-counter are a major factor in most cases. Alcohol for this generation right now is the biggest problem. So what can we do is increase the capability of effective screening and assessment, was something Alicia and I are going to talk about later. Develop age-appropriate interventions for current older adults, but also look at varied intervention and treatment protocols for baby boomers. One of the things we know that works is integrating approaches in physical health and primary care. So we'll talk about that in a little bit. We need to do education for physicians and other medical personnel. We need to look for teachable moments, which is one of the reasons this program for housing is very important. We need to screen for risky behavior in all settings, and we're going to talk about that, including health fairs, housing, across the board. So screening for older adults needs to be holistic because of the physical and co-occurring mental health problems that the older adult or cognitive problems the older adult may have. Certainly people can screen at routine medical exams. If it's never been done before, it should be done at age 60 or during major life transitions like menopause, empty nest, retirement, those types of things. If you're noticing problems, minor traffic accidents, loss of housing, ADL problems, driving abilities, like dents and things in the cars, people not completing their chores, mowing their lawn, it's time to sort of look at that. People may make excuses or hide or deny their drinking. They may get annoyed if they're having falls or blackouts or seizures, if they become incontinent, complaints of dry mouth, dehydration, malnutrition, muscle wasting, anorexia, memory problems, confusion, disorientation, slurred speech. Screen when people are drinking despite medical warnings, if there's arrest for drinking and driving, if there's falls, bruising, increased tolerance, if there's morning drinking, if there's neglect of homes, pets, bills, personal hygiene, irritability, problems with family and friends, withdrawal from social activities, problems sleeping, suicidal thoughts. Usually drinking is one of the ways people attempt because it gives them the oomph to do it. It sort of disinhibits them so they actually attempt it, and we'll see that in the emergency room. If they're agitated or aggressive, if they're complaining of nausea, vomiting, as I said before, losing weight, bloating. And there are screening instruments out there that are very good, very well tested. There's also screening instruments specific for older adults. The AUDIT is actually used with the SBIRT approach, and we'll talk about that in a little bit. There's the CAGE, which is the asking for questions. Do you feel the need to cut down? Do you get annoyed when people talk to you about it? Do you feel guilty about your drinking? Do you need an eye-opener? Okay. MASS-G is the Michigan Alcohol Screening Test. There's a geriatric version, and then we'll talk about the ARPS, the SHARPS, and the CARPS in a little bit. So the audit is 10 questions. It's either interviewed or self-administered. It's designed for use in medical settings, or you can actually use it anywhere. It screens for risky behavior. And so that's it. CAGE is really most widely used. 2 or more suggest a diagnosis of alcoholism. However, recent studies say that you need to supplement amount and frequency for older adults. It also has been modified in 2001 for illicit drug use. So the MASS-G is actually for geriatrics. It's 24 questions, yes, no. A score of 5 or more indicates alcohol problems. The ARPS, the SHARPS, and the CARPS. The SHARPS and the CARPS actually is computerized, and there's a model of learning motivation with that. But this is a self-administered 60-question questionnaire. It's usually done in primary care sites. It looks at medical and psychiatric conditions. It looks at symptoms of disease. It looks at medication use. It looks at function, health status, quantity and frequency. It addresses episodic heavy drinking. It looks at symptoms of alcohol abuse and dependence, and it actually looks at drinking after driving. And it classifies. So you go through and you do this, and then it classifies drinking as non-hazardous, so you don't have any risk, hazardous, that you're consuming above the risk, or harmful, that you are having adverse reactions, adverse events due to the drinking. So the interesting thing with the ARPS is hazardous or harmful drinking. Drinkers did not screen positive on the CAGE, the AUDIT, or the MASS. So you'll see it's expensive. I forget how much it is, but a lot of primary care offices are putting this in. So what it found is drinkers had medical conditions or used medications that put them at higher risk for having problems. So that's why the ARPS is a really good model to use. And how it works, I actually put an example in here. It's the learning model is attention, relevance, confidence, and satisfaction. So attention, do you know 1 to 2 drinks a day may be safe for some people, but for other people 1 to 2 may be dangerous, and why is that? Well, you said you had 3 drinks every day, and you've been diagnosed with hypertension. You're on Coumadin at least once a week and 6 other medications. You also felt depressed in the past 4 weeks. So this means that your alcohol may be risky. Experts recommend that men 65 and older consume 1 or more less drink a day. Medicines and alcohol interact. You're on Coumadin. You're taking 6 meds. And the depression issue, alcohol can make you even feel more depressed. So it gives you all of that, and it comes down with confidence and satisfaction. Here's what you should do. You should drink less. You should drink non-alcoholic wine or beer. Put orange juice and champagne. Don't drink at lunch. Don't drink alone. And speak to your physicians about ways that you can reduce the amount of alcohol you drink, ways to reduce the medications you're taking, and your hypertension and other medications, and you're at risk for depression. And the ARPS has been around for a while, but it actually has just been approved and being used within the past 3 to 5 years. But it's a really neat computerized program. I also gave you a list of substance abuse screening tools. There is the DAST, which is drug abuse screening. It's 20 questions self. It does not include alcohol. Drug use, the AUDIT is 11 questions self-reporting. Then there's the CAGE AID, which is the cut down annoyed guilty eye opener. And then the SSI, the simple screening instrument for substance abuse, I think is it's pretty lengthy, but it's pretty exacting. So those are out there, and all you have to do is Google them, and you can pull them up if you're interested. And this is the CAGE AID. Have you ever felt you should cut down on your drinking or your drug use? Have you ever felt annoyed? Have you ever felt guilty? Have you ever had a drink or use drug first thing in the morning as an eye-opener to steady your nerves or to get rid of a hangover? 0 for no and 1 for yes, and a score of 1 or above accurately detects 21% of alcohol users and 92% of drug users. A score of 2 or greater is clinically significant. Okay. In summary, what we need to be doing is gathering information and determining readiness for treatment. using formal instruments with trained assessors and clinicians. Older adults need medical workup, okay? And we need to try and use instruments for older adults like the MASG. Even that did not pick up on the significance for alcohol use with older adults. So we need to look at that. We need to look at specialties. We need to look at comorbid conditions as well. The single county authority is the Substance Abuse Authority in Pennsylvania. There's one in every county, and you just call your single county authority to see if there's any substance abuse services. In Pennsylvania, on the Coalition website, on the left-hand side, there are resources. And in there, we actually have listings of psychiatric, geriatric psych hospitals, psychiatric nursing homes, and in places that are specifically substance abuse treatment facilities that are specific for older adults. I think I looked at it on Monday, there are only 3 in the state, and they're all outside of Philadelphia. So, and they are specific for older adults. One is Eagleville, and I can't remember the other 2, but they are listed on the Coalition website with contact information. So we're going to spend the last 15 minutes talking about treatment and what's been done out there, what's out there, and what actually works. So once again, there are special needs for treatment of older adults. Especially different needs for late onset versus those with early onset. We need to be educating about aging and substance abuse problems. We need to address the life changes and help individuals understand the reasons, and if they've had a loss of a spouse, how to actually replace some of those losses, and it's therapy for older individuals. We need to motivate individuals to stay healthy by encouraging them to stay independent. And I found this a couple months ago, and it's from the TIP in 1998. You can see that they were really focusing on older individuals, really, really important types of things to educate and addressing some of the stigma issues. We need to educate and teach older adults ways to address issues of depression and loss, as I said before, how to increase their self-esteem and social network. We need to make sure that detox units meet special needs. I had a referral last summer, and actually I had the referral from 3 different people from 3 different contacts in the clinic as well as through the coalition. And this was a woman with severe cardiac problems who was addicted to, I think it was Ativan. And she called. I need to get off this. I don't know what to do. I need to be detoxed. Nobody would touch her because of her cardiac issues. So it was really, 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 really touchy. And we need to talk about triggers that may cause misuse, abuse, and addiction, how to identify those and how to redirect our thoughts, how to stay active or know that you're going to go to this party and you may be at risk for drinking, but what you can do to redirect it, that you go to the party but you go with somebody who's supportive, and if you start feeling like you're going to need to drink, that you actually can leave with them and get some support in the process of it. So there's all sorts of concrete cognitive behavioral things to do. Older adults need extended detox and medical stabilization. They need slower transitions between levels of care. They may have cognitive problems that you need to think about. Hearing, speech, and vision impairments are problems, especially on discharge and follow-up. They may need longer rest periods, relaxation, recreation. They may need to be taught how to do recreation. Nutrition issues can be an issue. Chronic pain and how to manage that without using addictive medications. Talking about the grief and loss issues and how social supports loneliness. The good news is that older adults are more compliant with treatment and have better outcomes than younger people, specifically the late onset drinkers. Baby boomers treatment programs are going to have to adapt over the next 5 years, and the sooner the better. Rehab units, older adults and addictions in the country, private treatment centers, only 18% address the needs. Approximately less than 5% of facilities have specific tracks for older adults. Programs are really rare. The Handley Center in Florida has been up and running for, at least 10, 15 years and really is focused on older adults. They have a partial program. They have step-down unit. They have detox. It's in Florida. Medicare, and this is as of 2012, I believe, Medicare will pay for the treatment of alcohol and drug abuse, and that was part of the problem before. Believe it or not, it wouldn't. And they will pay both in and outpatient settings as long as you're receiving services from a Medicare participating provider or facility, and the doctor states that the services are medically necessary, and the doctor is in charge of your treatment plan. Okay. So effective treatment models address aging, address families, friends, and support. They're non-confrontational. It's a little bit different than AA. Their peer support is extremely important. Motivational interviewing is the approach. Using psychoeducational workbook follow-up types of approaches, and we'll talk about that. The treatment needs, psychological, physical, cognitive, behavioral, problem-solving, interpersonal, discussing changing social status, death of loved ones, bereavement issues, social supports, which brings us to SBIRT. And SBIRT is screening, brief intervention, and referral to treatment. This is a different approach. It has been around probably for 15 or 20 years, and you can find it at AUDIT, which I'll also have that at the end. But it's screening, brief intervention, referral to treatment. It's very much health and wellness focused. It's a brief process. It's used for prevention. It also screens. It looks at risky behaviors. They use it across the board in primary care centers. It can be used in housing. It really normalizes the message, takes away some of the stigma issues. It has been approved by the Administration on Aging and SAMHSA, and it really targets community-dwelling older adults who are at risk or experiencing problems. And these substances include everything: alcohol, prescription meds, over-the-counter, or illicit drugs. It's offered in 70 states across the country. And I'm going to talk a little bit about it. Florida actually had a huge grant a few years ago and did it, and we're going to talk about that as well. But it basically screens to identify people at risk and give you brief advice, one-time intervention with a consult. You know, you're drinking, I see you're drinking 1 or 2 glasses a day, and you need to know that this could cause problems and, educate. Brief intervention is 1 or more short motivational sessions to really promote healthy behaviors. Treatment is 1 to 6 sessions of motivational enhancement therapy, cognitive behavioral therapy, and these are individuals who are trained. If people are dependent, they're actually referred into treatment for specialized services and case management. It is confidential. It's non-threatening, non-judgmental. You give feedback regarding health information or potential problems associated with level of alcohol or drug use. I'm wondering if the alcohol could be the reason your diabetes isn't responding or your hypertension isn't as well under control. So you sort of tie it in. You stress the client's responsibility, their choice about their actions. You must be clear about the need to reduce their consumption. Give them the recommended drinking levels. Offer choice in regards to future behaviors. Offer information on scientific evidence, the knowledge about the difficulty of change, and avoid confrontation. Be empathetic. Avoid using euphemisms, this sort of, oh, you're got a lot of pain, it's okay type of thing. They may deny, but you need to really be persistent and consistent. People who are inadvertently misusing are unlikely to be defensive about the need to change. They did not know this was a problem. Use active listening techniques. Confirm the problem. It is a problem because of this. It is a problem because your diabetes isn't under control. You've had how many falls? You had fractured your hip last year. Characterize the dimensions. You develop an individualized service plan. You refer for medical or psychiatric assessment as needed. The brief intervention is 15 to 20-minute session following the survey. Problem, you appreciate the problem, you identify the goals, summarize the health habits, standard drinking size, why the person drinks, reasons to cut down, develop a drinking agreement. We need to educate them, this is important, about risky situations that may trigger it, so they're aware that if they go to this party or this wedding, that this may be a problem, and what they can do in case it happens. And this is Florida's BRITE, and this is a big deal. They actually started doing it on their own. So it's Brief Intervention and Treatment for Elders. It's called BRITE. It identified non-dependent substance users or individuals with prescription medication issues, and they helped with effective service strategies for those who had more extensive need. It was a state-funded project for 3 years. They had 4 counties conducted screening, so almost 3,500 older adults were screened for alcohol, medication, illicit substance abuse and problems, and depression and suicide risk. What they found at this point in time was that prescription medication misuse was the most prevalent substance use problem. So it wasn't alcohol, and it was followed by alcohol, and then over-the-counter and illicit substances. Depression was the most common among abusers of alcohol and prescription meds. And those who received this SBIRT, the brief intervention, had improvement across all measures. So what they did then is they got another project. They got it funded by SAMHSA. The grant just ended in 2011. There's still data coming out of it because data takes years to pull this stuff out. So they focused on putting services in primary care emergency rooms, public health clinics, facilities, aging sites like senior centers, aging high-rises. The older adults had screenings, brief interventions, and brief treatment. If they needed, they were referred elsewhere. They had 31 sites in 18 counties. Huge. Over 20% of individuals had interventions, and they did a 6-month evaluation. What they found, there was a decrease in the use of alcohol and medications, as well as an improvement in depression. And look at this, 91,000 older adults were screened. Isn't that amazing? That's just huge. That's huge. And only in Florida would you, have that. Just absolutely amazing. So they did an excellent job in outreach in working with us. So I think this is a type of program that we know works. We know it works in prevention. It knows not only does it address the substance abuse issue, it also addresses depression issues. And people were screened and referred where they needed to go. And 20% received intervention, and that's absolutely amazing. That's very, very good, especially for this generation of older adults. And once again, it was non-threatening. They took away some of the stigma. They put it in places where older adults visited and were at. Okay, the other intervention that's out there, and this was done in Wisconsin back in like 2004, 2005. And when I first read about this, I thought this is just sort of funky. It's called Project Goal, Guiding Older Adults' Lifestyles. What it is 2 10 to 15-minute physician-delivered counseling sessions scheduled 1 month apart. And my score skepticism is what physician is going to spend 10 to 15 minutes with an older adult? Because the average time a physician spends with you in a doctor's office is 7 minutes. So anyhow, this was a grant. What they did is these 2 10 to 15-minute counseling sessions, there was advice, there's education, and there was contracting with a scripted workbook. So there's actually this workbook. Then 2 weeks after that, the nurse would follow up. And this is what's amazing. When you look at this, the older adults who received this intervention showed a 34% reduction in seven-day alcohol use, a 74% reduction in the mean numbers of binge drinking episodes, and a 62% reduction in the percentage of older adults drinking more than 21 drinks per week, and this is compared to a control group. So it's pretty substantial. Now, and I'm also going to go into how psychiatry diagnoses and what they've changed. So all this substance abuse is changing the way it's diagnosed across the board. So, and you'll see that Project Goal actually ties into this. So how we've diagnosed substance abuse previously, before 2013 when they changed, the Diagnostic Statistical Manual. This is how, DSM-5 is how psychiatry diagnoses, okay? So before May of 2013, we had a DSM-4R, 4 revised. So back then, substance abuse criteria, and look at this, because look at the stigma issues arise with this, and how it's changed in DSM-5. So DSM-4R said that substance abuse criteria is where there's recurrent substance use resulting in failure to fulfill major role obligations, school, work, or home, continued use in situations in which it's physically hazardous, recurrent legal problems, current substance abuse issues despite having persistent recurrent social and interpersonal problems. And then, so you have abuse criteria, and then you have dependence criteria where there's tolerance defined by an increased need to achieve the same effect. So in other words, you need more medication or more alcohol to feel that same euphoria. Withdrawal is manifested by either withdrawal syndrome of the substance, or you're taking another substance closely related to relieve or avoid the withdrawal symptoms, and the substance is often taken in larger amounts over a longer period of time than intended. There's also a persistent desire or unsuccessful attempt to cut down or control the substance use, and there's a great deal of time spent in activities necessary to obtain the substance or to recover from its effects. So that's the DSM-4. So and I just want to review because I think this could be confusing. So you have substance abuse criteria, and then you have, then you have substance dependence criteria. So in the DSM-5, what they did is they put everything under substance use disorder, okay? So substance use disorder and gambling are now found in a chapter separately in the DSM-5 called Substance Use Disorders and Addictive Disorders. So they totally changed it. And then what they did, which is really cool, they made the criteria, they merged it, so it includes alcohol, cigarettes, illicit or prescription drugs, and other substances. There is a single 11-item list associated with those disorders, such as failure to be able to cut down on it, failing to meet. So you have this list. And the diagnosis is then given on how many criteria on that list are met. So if somebody only has 1 or 2, there's no disorder. If they have 2 to 3, there's a mild disorder. Moderate is 4 to 5, severe is 6 or more. Okay? So they're really making it much more concrete. So the DSM-5 makes it easier to identify and address drug or alcohol problems, this is what's important, before they become dangerous. So it's actually screening and saying before. So you're educating. Individuals who drink heavy, like at sporting events, may be at risk, but they don't need lengthy treatment. Totally different types of things. And when you think about it, before it was really black and white, and people could just deny they have a problem because they didn't fit all of this. And we know that people with substance abuse do not fit neatly in those 2 categories. So it also makes it easier for primary care people to reimburse for screening for doing the Project Goal for alcohol and drug problems and to conduct short counseling, the DSM-5. It's one of the reasons they developed it. So you're actually educating people about the risks and making people aware of consequences. So it's not just saying you're an alcoholic, you have a problem, this is going on. You're getting to it before there is a big problem. There's a close correlation between the number of symptoms experienced by the person and the severity of the substance use disorder. And several studies demonstrate that abuse is not necessarily a precursor for dependence. Okay? So a spectrum in this new criteria addresses the broader context, and it may help allay some of those issues of stigma. And I hope that makes sense to people. I think it's actually a really positive move. So that's what you're seeing. I haven't seen it in process yet. We don't use this in our clinic because we're psychiatry, so we have to diagnose primarily psychiatric issues and dementia types of things. But if you think about this, really makes sense. Okay, what can we do with these issues of substance and medication abuse and use in older adults? So we need to increase awareness and education across population and professionals. I think we need to be putting commercials on TV, during the news, during football games. Use For approaches in prevention, intervention, and treatment, you need to use natural systems or pathways, senior center, high-rises. You integrate with healthcare, visiting nurses things, discharge on admissions to hospital discharges, reinforce it. We need to come up with ways to finance or incentivize developing models for prevention and education. We need to routinely screen for older adults in settings where they frequent. We need to deal workforce. We need to deal with settings with specialty hospitals for older adult populations. We need to include older adults recovering from substance use disorders in their planning. And one of the things that Pennsylvania has is we have county memorandums of understanding in all of our counties across the state. And 2 years ago, they actually required that in those memorandums of understanding that they address substance use disorders in older adults. So it's actually out there for Pennsylvania. I don't know if anything's been done with it, if they're working with people. I know in Chester County, mental health, substance abuse, and aging meet routinely and review difficult cases, as do probation and parole. So interesting concepts, once again, pulling everybody to the table. I think housing should be at the table because I'm sure you guys have many individuals there who could use these approaches and could use some help with substance use disorders. We need to create opportunities to bring evidence-based approaches and promising practices to frontline workers. Remember that reducing and treating these problems require an integrated system of care that combines medical and behavioral health. And this is from NASDUIT in 2009. We need to coordinate care with primary care. I can tell you the individuals in my clinic that have substance use disorders, I fax our note to their primary care offices so the doctor knows what we're doing and what we're seeing. I actually had somebody here, a primary care doctor, believe it or not, refused to treat a woman because she broke her contract with him. So really cool things are happening out there. And that's in central Pennsylvania, which is fairly conservative. We need to involve family members when appropriate. Of course, age-specific treatment, as I said before. Provide a continuum of plan of care that link individuals to older adult-friendly groups. And prevention, this is actually different than your PowerPoint because I updated some of these. I actually went in and got you some websites for some that weren't on there. But Project Meds is done in Bucks County, and it's medication education designed for seniors. They also do the medication take-back thing. Elder Health is huge. It's from University of Maryland. It's consumer education program for older adults and their caregivers. It's actually done through the School of Pharmacy at the University of Maryland. Senior Helping Hands is in St. Cloud Hospital in Minnesota. It's done through a college out there. It's an outreach program that addresses older adults with substance use disorders and mental illness. And then here is the early intervention for older adults through Florida BRITE. It's Dr. Hazlitt at the University of South Florida. The other resources out there, Get Connected. This is a workbook. It's from 2002. I'm actually listed there at Hershey when I worked at Penn State. I know it's old. It's like 12 years old, but the information in there is still appropriate. Some of this, even though the data out is newer, the projections are, as you saw, the same. The technical assistance, older American substance use and mental health, that's the link to that. There is the National Institute of Alcohol and Alcoholism. IREDIT is the Institute for Research, Education, and Training in Addictions. It is based in Pittsburgh. Pennsylvania has wonderful older adults things. The Administration on Aging, the American Society on Aging. Brown University has I actually took an older adult substance abuse program 5 years ago from Brown. It was online. It was a 6-8-week course. I got contact hours for it. Wonderful program. And that's the link to that. And then the Hanley Center is there in West Palm Beach, Florida. National Institutes of General Health, the geriatric, and you don't need a nurse to be a nurse to go in here, but the Hartford Institute for Geriatric Nursing at NYU. There's Hartford schools of nursing all over the country. Penn State has one. But they have a very good link on substance abuse. And I'm putting these in here for you guys for education and to use to share with people. CDC, I also put the link. There is, through the CDC Health Literacy, there's actually an online training on health literacy, and you can get contact hours on that. I took that the other year as well, and it's wonderful. It's very, very good. So questions. I guess we have time, Alicia. And I don't know.
We do.
I know we. Yeah, good.
Well, I'm going to start off with a question that probably a lot of people are thinking. So the majority of our attendees are service coordinators or property managers, that work in the independent living section of housing. And so we tell our social services, your job is not to diagnose. But
right.
They're very observant, and, they have daily interactions with their residents. So my question is, if as a person, in an independent living facility, you notice there are some behaviors that are going on, what is the best approach to have a conversation with the resident? Maybe you have your suspicions, but you're not really, really sure. How would someone approach a resident?
I think one of the things, a lot of times we get really angry at people, especially if stuff is happening that's really bad. And I think, and I've been doing older adult stuff for so long, but I think we take a concerned approach. This is happening. I'm not sure what's going on, but I'm really concerned about it. And I really want to try and be helpful to you. And I wouldn't even say initially, does your family doctor know? I would say I would give them information about substance use disorder. If there's a lot of alcohol bottles in their trash, I'm really and do it, individually, intimately in their apartment or in your office. But to say this is going on, and you can give them educational things with it, which I think is a real passive, soft approach with it. And think about the SBIRT approach, about how that's handled and how they sort of, or even the ARPs. I know you have diabetes and, you seem not to be getting out of bed in the morning, and I can't help but notice the alcohol bottles there. I'm really concerned. I'd like to help you. If you're not ready, that's fine, but I'm open to talk to you. And just leave the door open. That makes sense?
Yeah, so it's a non-threatening approach. And I was also thinking that we ask our properties to do at least one education or wellness program every 3 months. So, perhaps, this can be, a way to get it in there. We do have a question. The question is...
Alicia, can I just escape this? Will it pull up the chat for me if I just hit escape on my computer and get the PowerPoint?
I'm not really sure. You can try.
Okay, I'm just going to take that down. And I saw Scott's question about... I'm not going to do that. Okay.
If the CDC has a course for credit for service.
Yeah. Yeah, the CDC, that health literacy, maybe what I'll do is pull that up again. I'm sorry, you guys. The CDC, that health literacy CDC, that's it. That's the link to that training. And I think I got 5 credits for that for my nursing. I think they have other credits as well. It's all online, and I took it over a couple evenings when my daughter was in bed sleeping. But it's excellent because health literacy is, and I'm not kidding, it's a huge problem. It costs huge amount. That's one of the reasons you'll see in healthcare today, like I don't know if you guys know that hospitals, if somebody has congestive heart failure, and if they're re-hospitalized for the same diagnosis within 30 days, the hospital does not get paid by Medicare because the hospital is saying, you guys did not do a good discharge. You didn't educate the patient about their disease. You didn't set up good discharge planning. I mean, that's how serious. That's lack of health literacy. So people are like, oh, my gosh, they don't get paid. Well, it happened to my father this spring, and I know this stuff, and the hospital discharged him within 3 days and had daily aids in there. So there are things they can do, and it costs money. It costs billions and billions and billions of dollars in this country. So it's a good course, I think, for even lay people to take. It really, and it's not medically based. It just talks about the need for us to know our health care needs individually. Very, very important. So I hope that helps.
I did not provide the PowerPoint prior to the presentation.
Oh, okay.
Well, once everyone has viewed the recorded webinar, then I send it out as a PDF. So everyone will receive a copy of the PowerPoint, just not right now.
And just, Scott, it's the next to the last slide. It's the slide before the question slide. You'll see it. But if anybody has questions, you can email me. My email is very simple. It's Linda, Linda, @olderpa.org. Okay, and I only work 2 days a week for the coalition because I have a clinic. I run a clinic, but I check my emails usually on weekends at least once. So feel free if you have questions or problems, and even if you have somebody in your high-rise that needs help, email me and I'll see if I can't help your problem solve. Because I think it's I truly believe that we need to help each other because this population issue, these older adult issues are complicated. And they're really, really difficult. And just to remember when you approach somebody with a substance use disorder, don't confront it directly. Just, I'm concerned, I know you have health care problems. I know your daughter moved away last month and you seem to be drinking more and I'm just really concerned. I want to be helpful. Please let me know if there's just do a passive approach. Okay. Very, very important. Alicia, are there other questions there? Because I can't see the chat.
Oh, no,
and I don't want to mess up this.
No more questions. So